Okay guys, Timmy coming at you here again, and today what I'm going to do is I'm going to talk to you about stroke, or the fancy way of explaining it is cerebral vascular accident, CVA, or stroke. The old word used to be apoplexy. I don't know. Sounds like someplace you go to wrestle or something. Anyways, I'm going to explain to you stroke. And really, there's basically two causes for stroke, and you should be aware of these, right? You should know these. The first one is ischemic stroke. And basically what that is something's interrupting the blood flow through the artery of a brain. And the most common cause is a blood clot. And furthermore, the most common cause of the blood clot is due to narrowing of cerebral arteries, typically carotid arteries, with cholesterol. So just like in coronary artery disease, I explained to you, right, that you've got that artery, and over time what will happen is, hang on, I got it. I think I got it. Cholesterol will begin to build up. And as that cholesterol begins to build up, it's going to narrow that artery that supplies the brain. Now, when it gets really narrowed over time, and again, this happens over, decades, just like coronary artery disease. Because it's narrowed, that blood flows turbulently, and turbulent blood flow tends to form a clot. And that is going to interrupt blood flow to that part of the brain. And depending on what artery is blocked, supplying what part of the brain, that will tell you what's going to happen, the deficits that that person is going to have as a result of that particular artery being blocked. The other type of stroke is what's referred to as the hemorrhagic stroke. And basically what that is almost always due to, well, not always, but it's due to basically two big causes. Either there's a weakening in the wall of an artery, a cerebral artery, and then that weakened part ruptures, and because there's a hole in it, blood's going to start leaking out that hole instead of going to the parts of the brain that it needs to. The other big cause is trauma, and when somebody whacks you in the head, you fall down and break your crown. Sometimes you can bleed. And one of the most common causes of stroke due to trauma is what's called a subarachnoid bleed. Now, if you remember from anatomy and physiology, the meninges, the arachnoid layer, below it, in the subarachnoid space, is where cerebral spinal fluid circulates. But the subarachnoid and the arachnoid mater are connected, and it can kind of pull apart and cause bleeding. And that can lead to stroke too. But the most common cause of hemorrhagic stroke is typically aneurysm. And again, you don't really know that you have an aneurysm unless, number one, they find it serendipitously, meaning, okay, you might have some headaches, right? So they're going to do an MRI on your brain, and then they happen to see an aneurysm. The way most cerebral aneurysms are found is unfortunately due to when they rupture, and that's why cerebral hemorrhagic aneurysms, bleeding aneurysms, when they rupture, the person usually dies within a few minutes. That's just the way it is. There's not too much you can do. But with the other stroke, the ischemic stroke, that represents about 85% of all strokes. So I'm going to talk about that, right? So again, you should know the two most common types of stroke. That being ischemic, typically caused by a blockage in a cerebral artery, and it's typically caused by plaque buildup. And again, people who are at risk for stroke are also at risk for coronary artery disease. So the risk factors for buildup of plaque in your heart are identical to people who have buildup of plaque in their cerebral arteries, right? So let's look at this a little bit, right? The causes of ischemic stroke. And there's a few different causes, and I'm going to explain each one as we go through it. Number one, the biggest cause, as I said to you before, is cholesterol buildup in your carotid arteries or other major arteries of the brain, and then ultimately leading to narrowing of that artery and then the formation of a blood clot. Sometimes, though, the plaque itself, the cholesterol plaque can rupture. And when the cholesterol plaque ruptures, it will bleed. And that can actually produce a clot. So as the plaque ruptures, it will form a clot, and that clot can actually travel, and it will travel to the point where it simply can't move anymore, and it will cause the stroke. So that's really an embolus versus a thrombus, because it travels a little bit. The other thing that can cause it, and again, you remember, you're talking about the left side of the heart, right? The left side of the heart. We talked about the fact that a DVT, a deep vein thrombosis, is going to lead to a pulmonary embolus. A DVT cannot cause a stroke because it's going to block the small pulmonary vessels. So it is, in fact, problems on the left side of the heart that could potentially cause a stroke. And one of the big ones that can cause it is a condition called atrial fibrillation. Now, if you recall from the circulation of blood through the heart, I explained to you that the atria will contract and push some additional blood into the ventricles. Well, there's some people, like grandma and grandpa, they're walking around and they have atrial fibrillation where the atria don't contract, they quiver, right? So if the atria are just quivering, they're not emptying all that blood into the ventricle. And some of that blood can pool in the atria. It will remain in the atria. And if that blood pools, blood that doesn't move tends to clot. And that clot can break loose, right? Mitral valve, left ventricle, aortic valve, and boop to the brain, and you end up with a stroke. That's why a lot of people who are in atrial fibrillation, and if you've been in for a while, you're not getting out of it, they're put on anticoagulants to prevent that from happening. The other thing is that people can get left ventricular clots, thrombi, right? Especially people with dilated congestive heart failure. So if you remember in congestive heart failure, I explained to you that the left ventricle stretches and enlarges, right? And the amount of blood that's in the left ventricle in people with that dilated CHF before it contracts is a lot higher than in a normal ventricle. So when their weakened left ventricle contracts and ejects the blood out into the aorta, there's a lot of that blood that remains. And as a result, that blood that's remaining in the left ventricle can, again, pool, and it can form clots. And some of those clots can dislodge and produce a stroke. So those are the real big causes of the ischemic stroke. Now let's look at the other one, the hemorrhagic stroke. And again, as I explained to you, the most common is an aneurysm, and these are the most common places to develop an aneurysm in the cerebral circulation. And again, these are big arteries, and as a result, they supply a large area of the brain with blood. So if one of those aneurysms ruptured, you're going to have profound effects on one side of the brain or the other. Now, if you look at the differences between hemorrhagic stroke versus ischemic stroke, right? Again, ischemic stroke, cutting off blood flow, typically due to a clot, right? Represent about 85% of all the strokes that occur. And then hemorrhagic strokes, again, like I said before, they're very difficult to detect. The brain itself does not have any pain receptors. So if you get a headache, what you're really feeling is pressure of the pain receptors that line the inside of your skull. Your brain doesn't feel pain. It interprets pain, but it doesn't feel it. So a lot of times these strokes just happen and the person didn't know it. Sometimes though, when it does rupture, they'll experience what they refer to as the worst headache of their lives. And if someone says that, if you're a nurse in an emergency room and said, I've got the worst headache of my life, and you're doing triage, you need to get their fatty acid in because they could be having a hemorrhagic stroke. And again, time is brain tissue. The quicker you can treat these people, the less deficits they're going to have. And in some cases, if it's treated quickly and correctly, they don't have any deficits at all. You can actually prevent that by treating it very quickly. And then the hemorrhagic stroke, again, worst headache of their life. And again, they're really devastating. Once that aneurysm blows, if it's big enough, they don't do well. And then ischemic strokes can also result in TIAs, or those mini strokes, where grandpa or grandma may be talking to you and then all of a sudden they'll kind of look out into space, or they'll say, oh, I'm dizzy, I feel like the room is spinning, and then a few minutes later they're back to normal. Just so you know, they're forming blood clots, but we have inside our blood natural blood clotting busters. We bust the blood clot down and then reestablish that blood flow. So TIAs, or mini strokes, are a huge risk factor for having a major stroke later on. So anytime someone's experiencing mini strokes, they need to be evaluated right away, and they need to be treated to prevent that major stroke. And just as a review, what I want to do is just quickly, and I'm not, again, I'm not going to expect you to know all this, but just to have a general idea of the basic functions of the right and left side of the brain. And if you understand basically what the right and left side of the brain do, then you'll understand what are some of the deficits associated with a stroke that occurs in the left or right hemisphere of the brain, right? So remember that the left side of the brain is the analyzing parts, good math, right? Language, it understands facts, right? It sticks to the facts. And like sequencing, they can put things in order. The right side of the brain deals more with creativity, right? Imagination, right? They see the big picture, they can project, right? So remember, based on where the stroke occurs, that's going to give you an idea of some of the deficits that are going to happen with that person, right? So left-sided or right-sided strokes. And we learned in AMP, and I know you did, that the body is contralaterally innervated. And that's a fancy way of saying the right side of the brain controls the left side, and the left side of the brain controls the right side. So if they're experiencing left-sided weakness, they've experienced a stroke in the right side of the brain. All right? And then whether it's an ischemic or hemorrhagic stroke, it doesn't matter. What matters is which side of the brain was affected by the stroke and how much that side of the brain has been affected. So you need to understand those things. And the other thing is if you're really going to treat a stroke, because typically, you got about 6 to 8 hours from the onset of symptoms, maybe a little longer. But the brain needs a constant supply of oxygen. That's why if you choke somebody, right, if you squeeze their carotid arteries, in a few seconds they're going to be passed out, right? Because the brain needs that constant supply of oxygen. And the brain can handle a little bit of oxygen deprivation, but not that long. You're looking at hours in terms of how long you can have that blood flow cut off before death of the brain occurs. So that's why you should know, and they're going to go over this in clinical with you, the fasting, right? So if someone's experiencing facial droop and they have one-sided weakness, like their left arm is weak, their slurred speech, they can't repeat stuff, you need to get them to the emergency room. They are having a stroke. And again, the sooner they get intervention, the more likely they're going to be successfully treated. And again, it's not always successful, especially in hemorrhagic. And then the clinical manifestations versus left and right-sided failure, or I'm sorry, CVA. Again, the left side of the brain, right, it's comprehension, it's analytics. So these people, they're going to not be able to do math, right? And because they can't see the big picture like the right side can, they tend to be very anxious, right? They have a slow, cautious performance because they can't see into the future, right? And the right side is involved in coordinating movement as well. They're going to be paralyzed on the right side. So if the left side of the brain is damaged, they're going to be paralyzed on the right side. And because the left side of the brain controls speech, they're going to have what's called aphasia. They're not going to be able to form words. They're not going to be able to understand words. Now, right-sided, they're going to be paralyzed on the left side, and they're going to have left-sided neglect where, and I've seen this, where they will shave the right side of their face, they'll wash the right side of their face, they'll dress the right side of their body, and they will not do anything to the left. And it's actually kind of interesting to see. And then they got a really short attention span. Again, they can't see the big picture. And then the left side is more of, they tend to be impulsive. So with right-sided damage, you don't have any right side to say, hey, look, I think that's a bad idea. Don't do that. And they lose the perception of time. A half a day can go by and they're like, well, that was just 10 minutes ago. Or 2 days can go by and, well, that was, we just did that 5 minutes ago. So they'll lose that time perception. So again, understanding a little bit about the sides of the brain and their basic function will give you an idea of the types of signs and symptoms that they're going to exhibit. All right? Now, diagnosing it. Look, first of all, it's based on physical exam and symptoms, right? This is where understanding some of the signs and symptoms of a CVA are going to be critical. Again, knowing these signs and symptoms and then getting these people in for treatment, that is really the ultimate goal, right? Now, if the doctor thinks that that's indicative of a stroke, they're going to order either a CT scan or an MRI. MRI tends to be a little bit better because MRI is better at looking at parts of the body with water, and the brain's got a lot of water. And CT scan, it can detect bleeding, but it's not really good at detecting ischemic stroke because the CT scan really can't say, okay, this part of the brain lacked oxygen. But it is good at ruling out hemorrhagic versus ischemic. So, and this is very important. Before you can treat a stroke, you have to know which kind you're dealing with. Because if you give antithrombolytics to a person who's had a hemorrhagic stroke, you're just going to speed their time to death. That's why it's important before treatment begins to make sure that you determine the cause of the stroke. And then the other thing you want to do is you want to do EKG. You want to assess cardiac function. Do they have congestive heart failure? Do they have atrial fibrillation? All of which can form clots in the left atrium, left ventricle, like I talked about before. Then they'll do carotid Dopplers, see if there's plaque buildup in the carotid arteries, and that's the cause. And ultimately, they can do a cerebral angiogram, just like they do in the heart, to detect, and they'll inject dye and see if there's parts of the brain that are not getting blood flow. That also is good because now they know which artery is potentially blocked with a blood clot. And then an echocardiogram too. Again, you want to see, you can actually see on echo if there are actual clots or pools of blood that are forming clots in the ventricle. You can also look at for valve problems. One of the things that can cause a stroke is mitral valve prolapse and regurgitation along with rheumatic heart disease. You can actually build up vegetation, bacterial vegetation on the mitral valve, and that colony of bacteria can actually break loose and cause an embolus. All right, so you want to look at those tests, and then some blood work too. You're going to look at a CVC, and what you really want to do is look at the platelet count and see if they're bleeding. And then you're going to look at the pro time and the partial thromboplastin time. And we didn't go over this yet, but I have a video that I'd like you to watch for the final, and it's on blood clotting. So pro time looks at the intrinsic pathway, and the partial thromboplastic time looks at the extrinsic blood clotting pathway. Don't worry about that. What they want to do is they want to look at these two tests to see if their blood is clotting normally, or if they are on anticoagulants, are the numbers way off, right? Are they taking too much of this medication and their blood is really, really thin, and that would tend to lead the doctor to believe that it's probably a hemorrhagic stroke? Or were they prescribed this medicine, not taking it, and their blood is really, really thick where it is predisposing them to blood clots, and that could be causing an ischemic stroke due to a blood clot. And then the other thing they want to look at is they'll look at the blood sugar. And the reason they look at the blood sugar is hypoglycemia. If you recall, right, when we talked about that, low blood sugar can mimic a person having a stroke. Their speech will be slurred, they'll be weak, they'll be dizzy, right? So all of these can be indicative of stroke. So they want to rule that out before they start treating it for sure. Now, when you look at the treatment of stroke, right, again, as I told you before, and it's in big letters, those are capital letters, because that's important. Put a star there. You know, smiley face. Yeah, that guy looks kind of sinister. Anyways, you need to find out the cause of the stroke before you treat it, and I just explained to you why. And then once the cause of the stroke is determined, right, and for a CVA, a stroke caused by a blood clot, there's a drug called tissue plasminogen activator. I'm going to try this. Hang on. I'm going to try this. Watch. Alright, here we go. You got a blood vessel. You got me? Then if a blood clot forms here, that's a blood clot floating around in your blood in its inactive form, is this enzyme called plasminogen. It's inactive. Anything with gen after it is inactive. And when they give you TPA, TPA stands for tissue plasminogen activator. It activates the inactive plasminogen into the active enzyme plasmin. And that is like a little Pac-Man. And it comes in and num 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 num. and it breaks up that clot. So it's already inside you. They're just giving you a drug that activates it to break down that clot. The problem with that is that it has to be given within 4.5 hours of symptoms, at the onset of symptoms. And that's hard to do, right? Think about it. If somebody, they may be having a stroke, what if they're alone, right? And a lot of people, just like when they're having a heart attack, they're going to deny it. So a lot of times TPA, if the onset of symptoms was too long, the doctor can't do it because the benefits begin to gradually decrease after 4.5 hours, and it just isn't going to work. The other thing they'll do is they'll give them aspirin, and it doesn't do anything for the clot that's already formed. What it will do is just prevent new clots from forming, because it prevents platelets from sticking together, just like in the heart. And then the new one is the cerebral thromboectomy, and that's called the Mercy Retriever. And the Mercy Retriever stands for Mechanical Embolism Removal of Cerebral Ischemia. Who cares? I don't care. I want to show you how it works. Watch. They know you have a blood clot in the cerebral artery. They did the angiogram. You can't give them TPA, right? It's too late. But you got to establish a blood flow, otherwise this person's really going to be in trouble. They're going to lose a lot of function. So this is how it works. They do an angiogram on you, and they thread the catheter in. This is actually pretty cool. There's the clot. Looks like a turd. Now watch. Here, I'll move it ahead. Okay. They put the wire through the clot, and then watch. Then they put a plastic catheter over it. This is actually really cool. Now they got the plastic catheter in there, and then they weave this web here, and then watch what happens. It unravels and produces this like a little springy action. And then what they'll do is they'll temporarily cut off blood flow to that artery, so that you don't want the blood flowing through that artery. Otherwise, if part of that clot dislodges, now you got the same problem. So you're going to cut off blood flow through that artery, and then you're going to slowly remove the clot. And people thought that up. God, that's good. That is for the acute intervention of stroke if TPA cannot be used. Now, what? In the treatment of hemorrhagic stroke, what you have to do is, a lot of times you have to manage the symptoms, and then you got to get them to surgery. That's ultimately what you're going to do. Now look, just like any blood vessel, right? Just like any blood vessel. If the aneurysm ruptures, right? So let's say this aneurysm ruptured. The natural tendency of the body is to try to form a clot to stop that bleeding. Now look, if you form a clot, you don't want the pressure in those arteries to be high. If it is, it can dislodge that clot, and now you got problems. So one of the things that you do, or the doctor will do, is order antihypertensives, right? Lower that blood pressure. And also, look, you don't want a lot of venous blood going back to the brain. The more blood in the brain, the more blood in the skull, the more pressure in the brain. So you elevate the person's head about 30 degrees. And that's going to reduce the venous return of blood to the heart or to the brain. And that's what you want. You don't want a lot of blood going to the brain. So you lower the blood pressure, so less arterial blood or less pressure's going there. And you lift the head of the bed so that venous blood is not staying in the skull to increase the pressure. Because that's really, in many respects, that buildup of blood inside the skull, because the skull's fixed, that can, even if the bleed is somewhere else, that pressure can cause the brainstem to not work very good. And anytime you put pressure on the brain, so one of the signs that someone has increased intracranial pressure is they'll begin to seize. So in addition to that, doctors may give some anti-seizure medication to prevent seizures. The other thing they can do is they will use osmotic diuretics to try to draw any fluid off the brain and into the blood and try to get rid of it that way. Again, that's very temporary. But if they know they're bleeding and they can't stop the bleeding, right, with medical medications, then they have to do surgical interventions. And the two surgical interventions, if they can get at it, sometimes they can't get at it. The two surgical interventions are clips and coils. So here's a clip. What they will do is they will find the aneurysm and they will clip it off, just like a hemorrhoid. And we're not on that subject, but don't ever get hemorrhoids banded. Write that down. So by clipping this off, right, what will ultimately happen is the immune system will come in and then just turn this to scar tissue. And it'll be resorbed and it'll go away. The other way is the cerebral coiling. And basically what they do is they know where it's bleeding, so they'll stick a catheter in, and then they will put a coil and they will slowly add coil to this aneurysm. Now, just so you know, you're not supposed to have coil in your blood vessels. You should write that down. Are you writing that down? So, the immune system says, hey, that ain't right. And what does it do? It puts scar tissue there and prevents it from rupturing. So those are the treatments. So, little pathophysiology on stroke. Some of the signs and symptoms, again, be aware of the basic function of each side of the brain. And that way you'll understand some of the deficits that people will get, and you'll know which side of the brain is being affected, and then some of the treatments for it. And then remember the difference between hemorrhagic and ischemic stroke. And that ischemic stroke, 85% of all of them, all strokes are the result of ischemia. So it is reducing risk. So if you know the risk factors for heart disease, then you know the potential risk factors for stroke. The only difference there is if you have a family history of stroke. Yeah? All right, I hope that helped.